This is, as you can tell from the title, sort of a basic talk. The hope here is to really go over the fundamentals of narcolepsy, talk about narcolepsy type 1 and type 2, and talk about some things that we've learned in the last few years about what actually causes narcolepsy, and then wrap up on treatment stuff. It's as I said, it's meant to be sort of like an intro basic talk. And so I'm actually surprised. There's already 3 questions in the Q&A that I'm going to try to answer as we go. But don't be shy. It doesn't have to be basic questions. If you have more advanced questions, I'll do what I can with them. So, all right. Let's just start off with a very typical story. I think this is going to seem familiar to many of you. But this is a woman who's 23 years old, and she's got persistent sleepiness. And she says that she's been struggling with sleepiness since she was in high school. When she was in high school, she originally saw her pediatrician who tested her for the usual things that make people tired, anemia, hypothyroidism, chronic Lyme disease. And of course, they didn't really find anything. She sleeps 8 hours every night, and she usually feels pretty good in the morning. But by 10 o'clock in the morning, she's beat, and she really feels like she could go back to bed again. She drinks a couple of cups of coffee, but still needs to take 2 naps each day. And at this point, after having had this for several years, she comes to sleep clinic. And what really precipitated was she had a car accident. She rear-ended somebody when she was stuck in traffic, and her car started rolling and she bumped into somebody. So, that first part of the story, with the sleepiness is the most prominent part of the picture, is typical of a lot of different sleep disorders. And later, we're going to talk about some of the various things besides narcolepsy that can cause sleepiness. But the next features, I think y'all will recognize as being very distinctive. She says that occasionally she feels weak in her knees when she's laughing. And so once she actually fell to the ground at a party, she was laughing with some friends, and she literally was so floppy she couldn't get up for a minute or two, even though she was fully awake. She also says that if she gets sleepy when she's driving, she might imagine seeing something in the road. Like, this particular patient lives up in Maine, and she was driving on the Maine Turnpike late at night, and a bear jumped in front of her car, and she slammed on the brakes, and she realized that it was a complete hallucination. And then on a few occasions, she's found herself unable to move for a minute after awakening. And this is really kind of scary until she realized, well, it passes in a minute or so, but it sure is freaky. And so I think, as I said, for many of you, this is going to sound very familiar because this is a very classic story for narcolepsy with cataplexy. Everybody with narcolepsy has some degree of daytime sleepiness. And this is a tendency to doze off in the day, despite getting adequate and good quality sleep at night. And you remember from the story we just talked about, she sleeps 8 hours, and she actually feels okay when she first gets up, which is pretty common in narcolepsy. But she just, the sleepiness comes on, within an hour or two of being up for the day. You might know that rapid eye movement sleep, or REM sleep, is characterized by dreaming. Everybody has that. And your body's paralyzed, which keeps you from acting out your dreams. And the next symptoms of narcolepsy we think are kind of features of REM sleep, but they're sort of weirdly mixing in with wakefulness. And so one of these is cataplexy, where in response to some emotions, people have episodes of muscle weakness. And we think that's the paralysis of REM sleep that's somehow breaking through into wakefulness. There's also other REM sleep-like phenomena, like sleep paralysis. Again, it's the paralysis of REM sleep, but it occurs at the edges of sleep. And so the person wakes up, but the paralysis doesn't stop until a minute or so later. And then you can have hallucinations at the beginning or the end of sleep. These are called hypnagogic and hypnopompic hallucinations. And so it may occur as you're drifting off or waking up. And that also occurs, more or less in half of people. And one symptom that I find actually kind of surprising is that many people with narcolepsy actually have disrupted sleep at night. They just spontaneously wake up for no good reason. After 10 minutes or so, they go back to sleep again. But it seems kind of weird. If you're that sleepy during the day, you'd think you'd sleep great at night, but that's often not the case. So those are the sleep-related symptoms, but I do want to mention a few other things that are important to keep in mind. And this is especially good for doctors treating narcolepsy to be aware of. There's a variety of sleep disorders that show up at a higher than expected prevalence in people with narcolepsy. So obstructive sleep apnea, where the airway gets blocked off. That's sort of the typical picture with snoring. But also something called central sleep apnea, where people aren't initiating breaths as well as they should. periodic limb movements, which are twitchy kind of kicking movements of the legs and sometimes arms. REM sleep behavior disorder, where people actually act out their dreams. The paralysis doesn't really work while you're dreaming. And then sleepwalking, sleep talking, and night terrors, where particularly kids can have these sort of panicky responses. And so all of these things show up at about twice the expected prevalence. And we don't really understand why, but it's important to be aware of them, because sometimes, somebody with narcolepsy, to really get them feeling at their best, you need to fix, for instance, the sleep apnea or the limb movements, as well as addressing the narcolepsy itself. People with narcolepsy are also prone towards gaining weight. This is really most obvious in children with narcolepsy, where they can put on 20 or 30 pounds in the months after the disease begins. And adult people with narcolepsy, on average, weigh about 15% more than the general population. So the body mass index is a little bit high. Depression is also more common in narcolepsy, and we don't really know why this is. It could be a primary feature of the disease, or it could just be that it's a tough thing to live with. And so life is just harder when you're experiencing these symptoms every day. So it's a disease of young people. Narcolepsy typically begins between the ages of 10 and 20. And so this graph is showing age of onset in different age groups. And you can see the number of subjects in this nice study from Emmanuel Muñoz's group. On average, narcolepsy affects about 1 in 2,000 people, affects men and women equally. And what the graph is showing is when the age at which people first notice their sleepiness, and then when the cataplexy began. And usually the cataplexy lags behind the onset of sleepiness by a few weeks or months. But they both come on, again, between the ages of, say, 10 and 25 or thereabouts. Now, I want to go a little deeper into the sleepiness, because I think there's this misconception that people with narcolepsy all have horrible, crushing sleepiness. And that's certainly true for many folks, but it needn't be the case. Some people actually have rather mild sleepiness. I just saw somebody the other day who's basically getting by on 1 or 2 naps a day. Some people only take a little teeny low dose of modafinil, but then there's other people who might need 3 wake-promoting drugs to really be adequately functional. Many people with narcolepsy actually feel at their best when they wake up in the morning. And then as the day goes on, they get sleepy. And particularly in the early afternoon, it's tough. After dinner is especially hard. And of course, the sleepiness is most obvious when they're quiet, when they're sitting at a computer, when they're bored, when you're in a Zoom meeting that's just going on forever. But one thing I want to emphasize is that people talk about sleep attacks, and I don't really like that term, because it sort of gives the impression that somebody's stricken down, almost like they're having a seizure with sleep. But it really doesn't happen. I mean, people with narcolepsy can fall asleep quickly. They can sit down and a minute later they're asleep, but it's not like they're just, crossing the street and suddenly hit with a wave of sleepiness and fall asleep right there and then. But you get these weird states. And so, for instance, there's something we call automatic behavior, where people can, they're not asleep, but they're not really awake either. And so like a kid might be taking notes in class, and then it just sort of goes off into some scribbles or nonsensical writing, or somebody's driving on the highway and they just go a couple miles past their exit. So one thing that is really interesting with narcolepsy that you don't see so much in some other sleep disorders is that naps are often great for people with narcolepsy. If they fall asleep for 15 or 20 minutes, they often feel quite good afterwards. And so we try to include this as part of the treatment regimen as much as we can. So I would encourage you to put your questions into the Q&A, but I want to address one that came in early, where somebody wrote, I often find myself in a limbo state. I nod off and can't keep my eyes open when I'm trying to do things. And then I try to nap, but I can't fall asleep. How can I push myself one way or the other to either stay awake or fully fall asleep? And yeah, I think that sort of touches a little bit on this. Maybe it's sort of this brain fog / automatic behavior that the person's talking about. But it's interesting when this individual says that they can't actually fall asleep. And I wonder if that actually might be that there's a huge pressure to fall asleep, but if they're taking some wake-promoting medicines, Ritalin, Adderall, modafinil, something like that, maybe that's making it impossible to fall asleep, even though the person is exhausted. And so, as I said, I think fitting naps in across the day is great. But if you can't nap because of feelings like this, then maybe it's worth sort of thinking about the timing of the medicines to actually give yourself a little window where the meds aren't pushing you to stay awake. Okay. Now, cataplexy. This is seen in about half of all people with narcolepsy. And the important thing is that it's episodes of muscle weakness that are triggered by strong emotions. There's almost always some kind of emotional angle to it. The most common thing is laughing, joking with friends, telling a joke, but it can occur with other intense emotions like being really frustrated or angry, where you're just ready to strangle somebody. In contrast to feelings of faintness or seizures, consciousness is preserved. So if somebody has a full-blown episode of cataplexy and they collapse to the floor, they're still awake. So they can, hear what's being said around them. The frequency is all over the place. There's some people who will have a couple episodes their whole life and other people who will have several episodes each day. We sort of describe a spectrum of severity with the episodes. With severe episodes, the person completely falls to the ground. So it's bilateral, meaning affecting the left and right side. It involves pretty much all the muscles of the body except the ones for breathing. And the person will just slump to the ground. But for every time one of those severe episodes happens, people often have many episodes of what we call partial cataplexy, where they just get a mild weakness and it's just, for instance, limited to the face or their voice. And so their speech gets slurred, their eyelids close a little bit, or sometimes you'll see it in the limb, but it's not so bad that the person actually crumbles to the ground. This is a good place to address one of the other questions that came up, which is, what about status cataplecticus? And so that's a term that's used to refer to cataplexy that goes on for a long time. I didn't mention it on this slide, but most episodes of cataplexy last seconds to a minute or maybe 2 minutes at most. Status cataplecticus is cataplexy that lasts for a long time. There's not really an official definition, but if it goes on for 20 or 30 minutes, that's status cataplecticus, because usually these things are rather brief and self-limiting. Status cataplecticus is actually pretty uncommon. We see it in children who tend to have very bad cataplexy. And we see it in adults, but usually in adults, it's in a circumstance where they are rapidly tapering down or stopping their cataplexy medicines. And so if somebody is taking an antidepressant, for instance, to suppress their cataplexy, and then they miss it for a day or two, the cataplexy can come back with a vengeance, and you can have very bad, nasty, long episodes. And so the last part of that question that the person was asking is, what should you do with a really long cataplexy episode? So I think the question is, well, is there some ongoing trigger? Because I have heard some people say that, if they're really laughing and getting super silly with their friends and one of these things happens, they have to kind of like take a deep breath, kind of pull themselves away from the moment, think about something else and try to get those intense emotions out of their mind. Similarly, if you're really angry or something. So, a little bit of that is just sort of taking a breath and relaxing and trying to get rid of the trigger, if that's part of it. But certainly if you're having a really long episode, it's worth thinking about. It's like, did I take my meds today? Or did something else change that could have aggravated this? Marissa Palmer is asking a question that is sort of relevant for one of the prior slides, which is sleep inertia and brain fog. So sleep inertia is when people partially wake up in the morning, but have a heck of a time getting out of bed. They can't really wake up. Sometimes even opening their eyes is a struggle. Certainly getting up and out of bed and getting their clothes on can be really tough. That's sleep inertia. Everybody has it to some degree. Some people wake rapidly in the morning. Other people, it can take longer. But for some people, it can take a long time, like an hour or two. We generally see the worst sleep inertia in something that's kind of a cousin of narcolepsy called idiopathic hypersomnia. But it can occur also in people with narcolepsy too. And I'll talk a little bit about it as we get to treatments later on. Marissa also talks about brain fog, and I wish I had something more to say on this. One of the challenges with brain fog is we don't have a really great definition, and yet I hear it from people all the time. And I think that really what's going on is it's just, this clarity of thought is just not there. And it's probably because, the sleep pressure is so great that your brain is just not working. And so, maybe it's a good time to take a nap. If it lasts for long periods of the day, maybe your meds can get adjusted and stuff like that. There's been so little research on brain fog, and part of it is coming up with a good working definition to really target it distinctly. Wow, so many questions. I might have to stop at some point, but let me talk about the ones that are relevant here. Somebody asks, are constant muscle twitches considered cataplexy? That does get to an interesting point. When cataplexy first begins, there can be intermittent lapses of muscle tone. And so it actually can look a little bit like a tremor when it first starts. So here's a movie of a kid. He's actually being tickled here initially. And you're going to see in a second, he's going to collapse to the ground with a full-blown episode. That right there, I would say, is just typical kid stuff. But he's a little floppy here as he's dancing. And in a second, you're going to see an episode where there's sort of a gap in the film for a second, but he tends to just kind of melt. And so he has this continuous loss of muscle tone. But you see the way he's kind of bobbling around. Sometimes people will push back against this. And so you can see the muscle tone, it sort of drops and then it picks up again, it drops and it picks up. And when that happens, it can actually look like a tremor where people are sort of bobbing. And so you can see sort of tremor-like stuff, but constant muscle twitches, I wouldn't really, you'd have to see what the twitches are. I mean, I'm speaking as a neurologist, there's a lot of things that cause twitches, but in general, I wouldn't say that constant muscle twitches, in my mind, are consistent with cataplexy. I want to just touch on the triggers. This is a study that I'm very fond of, where they asked over 100 people with narcolepsy what were the things that generally triggered their cataplexy. And in dark purple are things that were always triggering cataplexy. Medium purple is often, light purple sometimes, or never. And what you can see is that laughing excitedly or making a sharp-minded sort of witty remark those are very common triggers. Telling a joke is right up there too. But there's other stuff down the list, like getting angry, being startled, tickling, things having to do with sex that can also be triggers further down. So it's a whole spectrum, because everybody's different. And so different emotions are going to strike people differently. But I want to point out that it generally sort of skews towards the more positive stuff, but there's certainly a variety of things that can bring it on. Okay, let me just see if there's anything else on cataplexy before. Oh, Karen says, my father has narcolepsy and is retired. He slumps to the ground from his bed during severe episodes. My daughter has to bring me, and the patient also has narcolepsy, and my daughter has to bring me to a sitting position when I have severe episodes. How likely will my grandson have narcolepsy? Well, I can't speak about your family in particular, but as a general rule, narcolepsy is not usually inherited. There are genes that definitely predispose people to narcolepsy, and I'm going to talk about that later, but the genes aren't the whole story. And so as a general rule, if a parent has narcolepsy, there's only about a 1% chance that one of their kids is going to have narcolepsy. So it's pretty low. And so I know it's a concern for a lot of folks, but it's pretty uncommon for it to run in families. Okay. I think I'm going to so many cataplexy questions. This is great. What about watching TV for children? Can it trigger cataplexy? Yes, indeed, it can. If kids have a TV show they love and they're laughing a whole bunch, it can do it. In fact, Giuseppe Plazzi in Italy has done research where they actually show kids cartoons and funny movies as a way of triggering cataplexy in the lab. And so anyway, your choice of, are you gonna have your kids watch those things? Does cataplexy get worse or better with time? That's a really great question. I think we tend to see the worst cataplexy in children, and in older adults, it's generally, it can be a concern, but it usually is not so bad. I think usually in the sort of young adult, middle adult years, it's kind of medium, but everybody's different. There's some folks with very severe cataplexy in their 20s and 30s, and others who had it bad when they were teens, but it's not so bad now. So as a general rule, I would say worst in kids, better in adulthood. Okay, I'm going to save some of these other ones because I want to make sure we get through some of the other slides too, but we'll circle back to cataplexy at the end if we have time. So, the big development a little more than 20 years ago was this discovery that many people with narcolepsy have low orexin or hypocretin levels. These are just two names for the same thing. It's a signaling molecule in the brain. It's a neurotransmitter. Some people call it orexin, some people call it hypocretin. In our group, we use the term orexin, so that's what you're going to see in my slides. Each dot in this graph is showing the orexin level in an individual. And so in the control subjects shown here on the left, you can see that orexin levels in spinal fluid range from the low 200s up to over 600, but on average, they're kind of around 320 or so. In people who have narcolepsy with cataplexy, you can hardly see it, but there's a whole bunch of dots piled up down here. Most of the time, their orexin levels are really low, less than 110 on this. You can see the dashed line here is the threshold we consider. So 90% of the time, people who have narcolepsy with cataplexy have these super low levels. In contrast, people who have narcolepsy without cataplexy, right? They could have sleepiness, they could have the hallucinations, they could have sleep paralysis, but they don't have cataplexy. 90% of the time, their levels are over 200. And so we really look at these as two distinct disorders now. And the thing that causes this reduction in orexin in the spinal fluid is a loss of the orexin-producing neurons. And so neurotransmitters are made by specific neurons in the brain. And on the left here, you can see half of the hypothalamus in a healthy control individual. And each green dot here is showing where an orexin neuron would be. But similar brain section from somebody who has narcolepsy type 1 with cataplexy, they have just maybe 5 or 10% of the normal number of cells. And so something is wrecking these cells. We think it's an autoimmune process. And so you can think of it in terms of molecular mimicry, and I'll explain that term in a second. This is a very sort of sciencey slide, so I'm going to skim over some of the details. But when you get sick, infected with something, there's these pathogens. They could be bacteria or viruses, but bugs, basically. And they're gobbled up by these cells that are called antigen-presenting cells. Those are immune cells. And the antigen-presenting cells take the bacteria, chop it into little bits, and then put pieces of those bacteria, little short sequences on their surface. And then it's called presentation of these peptides. So they present these little bacterial fragments on their surface, where they're then recognized by T cells, which are other immune cells, which make inflammatory chemicals called cytokines, which kill the bacteria. So this is a normal immune response. Your immune cells recognize the bacteria, chop them up, show them to other immune cells, which then start the inflammatory response. But we think that what happens in narcolepsy is that those same T cells that are great for fighting the bacteria or viruses accidentally also cross-react with something on the surface of the orexin-producing neurons, and they accidentally kill these. And so this is where that term molecular mimicry comes from, where by mistake, the immune cell thinks it's attacking bacteria, but it's actually attacking the orexin neurons. And so the evidence for this is that, Emmanuel Mignot, we, other groups in Europe and so forth, have found that people who have narcolepsy type 1 have immune cells, they're called CD4 and CD8 T cells, that are activated by the precursor of orexin. It's called preproorexin, but you can think of it as just orexin. And so the unfortunate thing is that we think these T cells just kill off the orexin neurons, and once they're gone forever. So when we diagnose narcolepsy, occasionally we do it by doing a spinal tap, but more typically it's done with the multiple sleep latency test. And for those of you who have narcolepsy, you know what I'm talking about here. So we first have somebody sleep in the sleep lab overnight, make sure they have adequate amount of sleep. Then the next day we ask them to try to fall asleep every 2 hours across the day. And they do that 5 times. And the things that we're measuring on this test is how quickly do you fall asleep? And do the naps contain REM sleep? Those are called sleep onset REM periods, or SOREMs, okay? And keep that little acronym in your mind because it comes up. The multiple sleep latency test is considered supportive of the diagnosis of narcolepsy if somebody falls asleep in less than 8 minutes and at least 2 of the naps contain REM sleep. So we call that 2 SOREMs, all right? So of the 5 sleep opportunities, 2 of them have REM sleep in them. We do the night in the lab beforehand just to sort of make sure their sleep is generally okay. We want to see at least 6 hours of sleep. And I put this adequate sleep in quotes because while the rule is that you need to have at least 6 hours of sleep, that's not enough for most people. And so it kind of bugs me that, we're doing this test sometimes in people who have not slept great on the prior night, because of course that's going to skew things a little bit. But probably the most important reason for doing that overnight test is it helps us rule out other sleep disorders. Like, we want to check and make sure somebody doesn't have sleep apnea, for instance. You probably remember some of the instructions, what we tell people before the multiple sleep latency test. We don't want to give them any medications that could alter their REM sleep, like antidepressants. Those need to wash out, and they often need to wash out for quite a while, like 3 weeks. They shouldn't be taking any wake-promoting medicines like Ritalin, modafinil, et cetera, in at least several days, but usually we want to see those gone for a week to get them fully out. And we want to see that they've slept decently for the last 2 weeks, getting adequate amount of sleep each night. And so we'll do a sleep log, or we can actually put a little wrist act a watch on them and document how much they're actually sleeping. It's like a Fitbit. So with these test results and with the understanding of the orexin system that I just talked about, doctors and researchers now talk about 2 types of narcolepsy. And the short names for these can be NT1, narcolepsy type 1, or NT2, which is narcolepsy type 2. So narcolepsy type 1 is narcolepsy with cataplexy. In fact, that's the old name for the disorder. These folks have sleepiness every day, and they have cataplexy plus a positive multiple sleep latency test. Remember, that's the test where you fall asleep in less, if it's considered positive if you fall asleep in less than 8 minutes, and at least 2 of the naps contain REM sleep. Now, you can actually skip past that if, that another way to get diagnosis is just to get a spinal tap and measure the orexin level. And this is a good test because it's super concrete. It's like your orexin, in general, it's like your orexin level is really low or it's normal. And sometimes it's just easiest to just simply go ahead and just do a spinal tap. And because what if somebody's got depression and they can't really come off their antidepressants? That's going to mess up the multiple sleep latency test, but we can still go ahead and measure the orexin level. And so it's a nice option, and the test is commercially available. It's just a matter of setting up to have your spinal fluid collected through your doctor's office. Narcolepsy type 2 is narcolepsy without cataplexy. So they have sleepiness, and the confirmatory thing in this case is that they have a positive multiple sleep latency test. And we don't have another really hard biologic marker. Like the orexin level isn't useful because these people have normal orexin levels. I honestly, I think that in most people, narcolepsy type 1, we can diagnose with some confidence. Narcolepsy type 2, I often have my doubts. It's like, is this really narcolepsy? Are we missing something? Could there be something else? Because the truth is, there's several things that can cause a positive multiple sleep latency test. And so I always feel a little bit wondering when I'm working with somebody who has that. So people are working a little bit on trying to figure out what causes narcolepsy without cataplexy. One idea is that maybe they do have some loss of orexin neurons. It's just not as bad. Jerry Siegel's group looked at the brains of 2 people with narcolepsy type 2 who had died, and they found a moderate loss of the orexin neurons, not as bad as in the narcolepsy type 1 patients, but some partial loss. And so that's kind of interesting. Maybe that explains why the symptoms are somewhat milder. And it is true that of people who have sleepiness but no cataplexy, and they meet the criteria for narcolepsy type 2, about 20% of folks who have that clinical picture actually do have low orexin levels. And if that's tested for and found, then they would be recategorized as narcolepsy type 1 because they meet that low orexin criteria. And some narcolepsy type 2 patients have intermediate CSF levels, which fits with this idea of a partial loss of these cells. If you take some of these patients who have these intermediate or that's supposed to say, or low CSF orexin, follow them for a long time, actually about a third of them do start having some cataplexy later on. And so maybe there's a slow loss of orexin neurons in those folks, or maybe it just takes a lot to trigger it. So this idea, so I do think there's some people with narcolepsy type 2 who I'll just say kind of merge into the narcolepsy type 1 category with perhaps some partial orexin neuron loss. But it could be something completely different. It might be that they're making orexins perfectly fine, but the orexin receptors are just less responsive, or maybe it's just something that we haven't even got clues about yet. It has nothing to do with orexin or hypocretin signaling. Okay, now this slide's important because, as I mentioned, when somebody has, particularly with narcolepsy type 2, we really have to think hard about, is there something else that could make this person sleepy? Are they getting sufficient sleep? And, one of the useful questions here is, I ask people, if you're just on a really quiet, lazy vacation, you're sleeping as much as you want every day, how much do you sleep? How much do other people in your family sleep? The average sleep needed for an adult is 7.5 to 8 hours, but some people come from families where everybody sleeps 9 hours, and maybe that's what you really need. As I mentioned a couple of times before, we want to make sure that there's nothing else disrupting sleep that could contribute, like sleep apnea, periodic limb movements, pain disrupting sleep, for instance. Circadian rhythm disorders are where your body clock is out of sync with your normal sleep rhythms. And so, like this is obviously a big problem for a lot of high school and college students, where they can easily stay up till 2 in the morning, but then it's really tough to get up at 8 in the morning. And so, when somebody says, oh, I have a lot of sleep inertia in the morning, I just really want to go right back to bed. We got to think about, is it possible their body clock is running on the later side? And so I mentioned before that most people with narcolepsy actually feel pretty good when they wake up. But if somebody's really tired in the morning, I definitely think about a circadian rhythm problem. We've got to talk about sedating medicines, right? Because there's a bunch of things that are used, medically, like epilepsy meds, antipsychotics that can make people drowsy. Whole bunch of neurologic disorders. I don't think these are super relevant because these are usually things that occur in older folks, but certainly like traumatic brain injury, that can make people sleepy. Prader-Willi syndrome, that's a genetic thing. This is probably, psychiatric disorders is probably the biggest consideration, I would say, where, depression, anxiety, and things like that make people tired. It's pretty common. And so sometimes it's really challenging to tease apart how much of the tiredness is from the depression or anxiety, how much of it is due to narcolepsy, and how do these interact. And it's especially hard thing to untangle because, as I mentioned before, people with narcolepsy are more likely to have depression. And at some point in the person's workup, you want to make sure we're not missing some obvious medical thing like an underactive thyroid, adrenal glands not doing what they're supposed to, kidney, liver problems, anemia, things like that. It's possible. There's some small evidence that even obesity makes people a little bit tired. Okay. So let's switch now to talking about how to make narcolepsy better. And there's some questions along these lines that I'll try to integrate in my responses here too. But before talking about medicines, I do think it's important to think about just day-to-day stuff that people can do to help themselves feel most alert. In terms of helping with your daytime sleepiness, you really got to make sure you're getting sufficient sleep at night. And again, you'd be surprised how many people I see in sleep clinic when I ask them what their optimal amount of sleep is, they don't really know. And they say, well, I'm just so busy. I'm going to just only go all the time. I get 6 hours of sleep. And yet, then when you push, you're like, well, on weekends, I sleep 8.5 hours. It's like, okay, I think we're learning something here. So understanding what's good for you is important. I think naps, as I mentioned earlier, can be really great. They don't need to be super long. Most people with narcolepsy, if they sleep for 15 or 20 minutes, it really helps charge their batteries, and they're much more alert for the next hour or two afterwards. As I've mentioned before, we want to make sure we're not missing some other sleep disorder. And if there's a problem there, like sleep apnea or insomnia for whatever reason, maybe we want to address that first. Because, I've certainly seen people where, they come in, we say, oh, kind of a story for narcolepsy, but you also got sleep apnea. So we'll fix the sleep apnea. Maybe we give them CPAP or something. And they say, oh, okay, I'm somewhat better, but I'm pretty sleepy still. It's like, okay, there's clearly more than one thing contributing to your daytime tiredness. Many people with narcolepsy talk about how certain foods or heavy meals can make their sleepiness worse. And so it's particularly since people with narcolepsy are prone towards gaining weight, it's good to just think about, what you're eating and the timing of your meals and so forth. And when working and studying and being in school or so forth, think about what can you do to help improve your alertness. Do you want to use a stand-up desk? Do you want to move around? If it's a student, maybe they want to be in the back of the classroom where they can actually stand up and stay a little bit physically active to help improve their attention. You want to use ample light. Working with other people in a stimulating environment is great. Of my adult patients with narcolepsy, I think some of the people who are most thriving in their work are like elementary school teachers with narcolepsy, because it's such a stimulating environment. They're just going all the time. But once the kids leave at 3 o'clock in the afternoon, they just, they can put their head on their desk and go to sleep. But in that very stimulating environment, it helps. And so, it's good to think about when you're, if you're a young person thinking about what career might suit you best, you might want to think about a stimulating environment like that. For the cataplexy and other symptoms, I think, understanding the triggers is really important. I don't want people to try to avoid emotional situations. I had one guy who said he didn't want to go to his daughter's wedding because he knew he was going to get very emotional and he didn't want to make a scene by having cataplexy. And that's just so sad because we actually have some very good meds for suppressing cataplexy. And my hope is that with those meds, people can really experience the full range of emotions and not have to throttle things down. Having said that, I have had a few patients with cataplexy where it can go on for a long time, and they have benefited from some counseling and cognitive behavioral therapy to just kind of think about ways to help if they get in that situation and the cataplexy is just really going on for a long time, to help, as I said before, take a breath, kind of set those emotions aside for a little bit. Okay, so I got a few slides here on medicines, and I'm going to go through these pretty quick because I think the details and the doses and so forth aren't so pertinent, but it's good to just make sure we get them all out there. So let's start off with talking about meds that can improve alertness. And since the 1940s, doctors have used methylphenidate and dextroamphetamine to help people with narcolepsy stay awake. I've got some of the brand names for these meds written in the parentheses, and the generics are in the bold. And as a general rule, we use up to as much as 60 milligrams a day of these stimulant medicines, and they come with all kinds of issues. I think for those of you who take these, you're probably familiar with the fact that they can make people irritable, they can cause headaches, they can cause diarrhea. If you take them too late in the day, they can cause insomnia, or as we said earlier, they might foul up your ability to nap in the day. Hypertension can be an issue. They're inexpensive and they can be pretty effective, but they definitely come with baggage. Modafinil came out about 25 years ago, and it's pretty commonly used medicine because it's pretty well tolerated. 15% of people get headaches, about 5% can get nausea. It's, I would say, a little bit gentler than the amphetamine type medicines, but it's sometimes a nice kind of, I think of it as sort of like a foundation medicine where it can give you sort of reasonably stable wakefulness across the day. And then sometimes we'll add other things on top of it. Oxybates. So oxybates is the name for this general class of medicines. The active ingredient in all of these is gamma hydroxybutyrate, or GHB. The brand names are Xyrem, Xywav, and Lumryz. This is really different than anything else. All the other medicines that I'm talking about are meds that people take during the day. Oxybates, you take a dose at bedtime, and for many of these, you take another dose halfway through the night. It's a super sedating medicine, and by some process that we don't really understand, people start to have improvements in their alertness in the day, and their cataplexy often gets better. They have a reasonably high incidence of side effects. About 20% or so of people actually need to discontinue them because of side effects. And the side effects are kind of like what you'd expect with a lot of alcohol: sedation, nausea, dizziness. We worry about people walking to the bathroom at night. We worry about giving these to older folks. We definitely don't want people to take these in combination with anything else that's the least bit sedating. So no alcohol, no other sleeping pills or anything like that. So Xyrem and Xywav are given twice a night and sometimes even spread out into 3 times a night. Lumryz is a new one that just came out within the last year, where it's a once nightly version. And there's a question about that one. Let me just see. Somebody was asking how patients have been doing with it. How's the transition? Is there a particular patient you suggest try this? It's kind of a long conversation. I think that Lumryz is a very nice choice for people who sleep through that second dose of Xyrem or Xywav. If they're missing that dose a lot, Lumryz is something to really think about because it's just easier. You just take it at bedtime. In general, I think the efficacy and the safety issues are actually pretty similar across all 3 of these. One thing I would say in favor of the older products, the Xyrem and the Xywav, is that we can adjust the doses with a little bit more subtlety, as well as we can adjust the timing. Lumryz is super convenient, but with the other, there's sometimes like we will play around with the timing of the doses to try to help get the most stable sleep across the night. And that's something that, at least at the moment, we can't really easily do with Lumryz. And so what the first part of this question was, how have my patients been doing? And the honest truth is I only have a few people who have transitioned over. And everybody has their own individual reasons, but any doctor who really understands narcolepsy would be familiar with all of these medicines. And it's that would be good to have that conversation to ask, what might suit you best. the Lumryz comes in sort of fixed units, and so you can't sort of fiddle with the doses in the subtle way you can with the other medicines. Okay. Let me just see if there's anything else that fits with this. Wow, so many questions. I just want to see if there's anything on meds. Okay. Wow. I hope we can get to these. So Sunosi is another wake-promoting med that just came out in the last few years. It's a stimulant kind of medicine. It's not technically it's not a stimulant, but it works through the same neurotransmitters in the brain. Pretty well tolerated though. Headache and nausea are the biggies, pretty effective. It's got nice wake-promoting efficacy. So it's a nice combination of pretty low side effects and pretty strong efficacy. Pitolisant's another new medicine just in the last few years. Again, well tolerated, easy dosing. You just take it in the morning, just like the Sunosi. And for some people, it just works great. I can't tell you upfront what kind of patient is most likely to respond to any one of these. And oftentimes we'll start with the least expensive, then we go to the more expensive ones. And on the right with the little dollar signs, I'm trying to give just sort of a general indication of the prices of these things. And I'll just say that, some of these can range from a few $100s a year to over $150,000 a year. And so, I certainly think that's a consideration. Now for cataplexy, we often use antidepressants. And in our clinic, we use venlafaxine a lot. But those are the brand names of Effexor. And usually a very low dose is quite good. You can get a 75, 80% reduction in cataplexy. And at these low doses, it's pretty well tolerated and it's cheap. So it's a really nice thing to start with. Fluoxetine, which is Prozac, same, low doses, pretty well tolerated, pretty good efficacy. One of the meds that's actually most potent is clomipramine. It's an old-fashioned type of antidepressant. And I mention it because if nothing else works, clomipramine is going to work usually. The trouble is it's kind of sedating and it can cause a dry mouth and urinary retention and stuff like that. So we don't use it too much anymore, but it works fast and it's very, very effective. It's just a little harder to tolerate. The oxybates, as I mentioned before, are also good, very good at suppressing cataplexy. And so they have the nice benefit of helping address both the sleepiness and the cataplexy. And pitolisant also can cover that similarly. So what you can see is that, from a convenience perspective, sometimes you can get all that you need from an oxybate or pitolisant, but it's pretty common in a lot of narcolepsy patients to take multiple medicines where we kind of tweak the doses to fit what they need. So even on these medicines, many people with narcolepsy still have problematic sleepiness. They still have brain fog. They still have occasional cataplexy. And so there's a number of drug companies who are developing new generations of medicines. And I just wanted to list some of them here. So reboxetine is moving along. It's in phase 3. This is a new medicine that would be used for cataplexy and probably will help with sleepiness to some degree. Mazendal has been used in Europe for ages and is now being further studied in phase 3 trials. Oh, I should mention, when a drug is under development, first there's phase 1 to make sure that it's actually just plain safe. Phase 2 to see if it actually can help somewhat in narcolepsy. And then phase 3 is the big studies where they have hundreds of patients to really definitively answer the questions about efficacy and safety. And so reboxetine and Mazendal are now in phase 3. There's another stimulant medicine related to methylphenidate or similar to Ritalin, this Sir-Dex methylphenidate, which will probably be another sort of wake-promoting med. And then the next two you'll see there are orexin receptor 2 agonists. Now remember, narcolepsy type 1 is caused by a loss of the orexin neurotransmitters. Narcolepsy type 2 might be due to a partial reduction in orexin signaling. And so there's a really strong interest in trying to make medications that mimic the effects of the native orexin. And so Takeda is making this TAK-861. Merck has a compound that they haven't really said much about, but it's almost certainly an orexin agonist. And there's other companies too that are working on these, Alkermes, Jazz, and so forth. And so these are all in various stages depending on the company. But the Takeda drug is now starting in phase 3 trials. And I think as a general rule, there's a lot of excitement about these orexin agonists because the hope is it's going to really replace what's missing for some patients. The group at Emory University is studying clarithromycin, which seems to have some alerting effects, though it's not super clear just yet, but it's still moving along. I want to just give you a taste here of what orexin agonists can do. And so this is a drug that was moving along nicely, but then it ended up with some toxicity problems and it was discontinued. It's called TAC994. It's an orexin receptor 2 agonist. So it binds to and activates those orexin receptors. And so this is from a pretty good sized study, a phase 2 study, where the endpoints were similar to the things I've talked about, but they require a little explanation. So people were treated for 8 weeks, and then they had what's called a maintenance of wakefulness test. And what this is it's a test where 4 times during the day, you sit in a comfy chair for 40 minutes in a dimly lit room and you gotta stay awake. When people with narcolepsy are treated, and this, I hope this is not obscuring things, people with narcolepsy type 1 are treated with placebo, okay, inert stuff. They fall asleep in 4 minutes. They're trying to stay awake for the full 40 minutes, but they fall asleep in 4 minutes. When they get treated with the low dose of TAC994, they stay awake for 31 minutes. When they get the higher dose, they stay awake for 35 minutes. And at the very highest dose, they're staying awake for 39 minutes. It's honestly really impressive. It's better than any other wake-promoting effect we've seen. The Epworth Sleepiness Score is a questionnaire that you might be familiar with from visits to sleep clinic. It goes from 0 is no sleepiness, 24 is horrible sleepiness. On placebo, the subjects have scores of 14, which is in the mild to moderate range. And with the various doses of this 994 drug, the scores go down to 5, which is well within the normal range, 3 or 1. So basically, subjectively, people are not sleepy. And their cataplexy goes from about 10 episodes per week down to just 1. So anyway, it's a really impressive effect. However, having said that, this is a drug that's no longer in development, but the hope is that the other orexin agonists will show similar benefits. All right, so just to wrap up our main points, and then I'll get to some of the questions. We talked about how narcolepsy causes chronic sleepiness in all patients, but some people also have cataplexy, hallucinations, and sleep paralysis. Narcolepsy type 1, NT1, caused by a loss of the orexin neurons, but the cause of NT2 is unknown. Maybe a partial loss, but really I wouldn't bank on that necessarily. We talked about some of the meds that can be used. And I just wanted to leave you with that message that there's a lot of stuff under development, which I think is pretty exciting. And so the hope is we're going to have even better and more effective medicines in the not so distant future. So I'm going to, actually, I'm going to keep this slide up here because somebody actually had the question about what's the difference between type 2 narcolepsy and idiopathic hypersomnia. And so this is kind of a cousin of narcolepsy. And these folks also have chronic sleepiness, but many of them also have difficulty waking in the morning. They have this sleep inertia. And if you do the multiple sleep latency test, it shows that they fall asleep in less than 8 minutes. But this is important. They don't have that tendency towards REM sleep in the day. So fewer than 2 of their naps contain REM sleep. An even better way to diagnose it is by doing really long sleep recordings and looking to see if somebody has more than 11 hours of sleep. And this table actually shows some of the contrasts between the different types: narcolepsy type 1, narcolepsy type 2, and idiopathic hypersomnia. Again, they all have sleepiness. Cataplexy is only in narcolepsy type 1. Low orexins only in narcolepsy type 1. But that tendency towards sleep onset REM periods on the multiple sleep latency test is seen in both types of narcolepsy, but not IH. That's the crucial distinction. Really long sleep, more than 11 hours, is pretty common in idiopathic hypersomnia. And sleep inertia is also very common in that, but less common in the narcolepsy disorders. Okay. So I am going to now turn to questions. And Monica, I don't know how long you want to go on for. I'll stick around for a while, and I'm just going to take it from the top here.
That sounds great. Thank you.
Well, the first question is a puzzler for me. Is it normal for your hands to hurt if having an attack that affects your hands and arms? Mine clamped together in a claw shape and impossible to pry open, and they hurt at the end. It can last for 5 minutes. That sounds more crampy than cataplexy. When somebody's having an episode of cataplexy, their limbs are floppy. There shouldn't be an increase in muscle tone. And so for that person, I would actually say it would be really good to see a sleep doctor who's also a neurologist and maybe dig into that a little bit more, because I get it why it might hurt if your hands are cramping up like that, but that is pretty uncommon for cataplexy. Next person saying, when I'm usually experiencing a cataplexy episode, my legs will often jerk forwards and then I feel kind of startled. Yeah, well, being startled can sometimes trigger cataplexy, though it's uncommon. And as I said before, sometimes there are these jerky movements at the beginning of it. And so again, there's these sort of drops in muscle power and then it comes back again. So there's this kind of flickering. And so you can definitely see kind of jerky movements as it first begins. But usually if that's going on for more than 5-10 seconds, it then sort of gets, the weakness gets worse and the person will then slump down. Okay, here's one that has to do with that sort of brain fog and so forth. If I, quote, go away for a few seconds, my eyes are open and I might still be typing or writing, but if somebody speaks to me, I can't respond. Is this a type of cataplexy? And you know what? I think that's probably more like automatic behavior or horrible brain fog, where you're not awake, but you're not asleep, and it's kind of this in-between thing. And I think perhaps it's hard to respond because you're just so zonked and drowsy. I mean, it could be cataplexy, but I think if it was cataplexy, I'd expect that you wouldn't still have your eyes open, because eyes tend to close when people have cataplexy. Okay, another question from Sakara. Are there any tips to identifying your cataplexy triggers? I don't know, very individual. That list that I showed earlier, that slide that showed a bunch of triggers, maybe it's sort of worth reflecting on that a little bit to ask yourself. But I think most people kind of figure it out in time of what are the things that usually push their buttons. Shannon asks, my daughter, who's now 20, was recently diagnosed, but she doesn't have cataplexy. It's often impossible to wake her up in the morning. She doesn't hear her alarms and doesn't react to them, even though they're very loud. We often have to wake her up and it's difficult. Similar issues to what previous participant mentioned about waking up. So this gets to that whole question of sleep inertia. You might remember on the last slide that I showed how sleep inertia is very common in idiopathic hypersomnia. We see it somewhat in narcolepsy type 2, and we see it occasionally in narcolepsy type 1. But it's an interesting question of what this young woman might really have. And I want to just emphasize, too, that there's a lot of 20-year-olds who have a delayed internal body rhythm, a circadian rhythm disorder, where their body clock is just not rousing them in the morning. And so if I was talking to this person in clinic, I might say, so how do you feel at 10 o'clock at night? And if she says, oh, I'm raring to go. That's my best time. I get lots done between 10 o'clock and midnight, but I can't wake up at 8 o'clock. That would be a very good picture for circadian phase delay, where her body clock is running late. And that's one of the things that makes it hard for her to rouse. Now, if she's going to bed at 10 p.m. and she still can't get up at 8 a.m. having slept solid 10 hours, then I'd be thinking more like idiopathic hypersomnia with that really bad morning sleep inertia. Okay, Taylor asks this very sophisticated question on any thoughts on the epigenetic silencing of orexin neurons suggested in a research paper this last year. It would be nice if the neurons are silenced rather than dead. I agree, it would be nice. I think you might know that this paper is kind of controversial. I could go into some of the scientific concerns that I have around it, but I wasn't convinced by the paper. I am fully supportive of people pursuing this and trying to understand it better, and I would love to think I'm wrong. I have to say, based upon the evidence I've seen thus far, I think there's substantially more evidence that the orexin neurons have been killed off and they're not going to come back. But if we can actually, if I'm wrong, that would be lovely, because if there's a way to undo this silencing and get them doing their thing again, that would be super. Next question is, can you have cataplexy but not narcolepsy? Like if you have sleepiness and cataplexy, but a normal MSLT and normal orexin levels. Ooh, super hard. So let me just take the first part of it. Let's just say, can you have cataplexy but not sleepiness? So first off, nearly everybody with true cataplexy has sleepiness. There's a handful, like literally half a dozen people who have been described in the medical literature over the last 20 years who have cataplexy and no sleepiness. And those are people who have pretty serious problems in their brain stem. They have like a brain tumor or something like that. And they have lots of other symptoms, lots of other neurologic symptoms like double vision, incoordination, can't talk, loss of sensation. It's pretty obvious that they have a serious neurologic problem. So to have cataplexy, but without sleepiness or other symptoms of narcolepsy, and to have a normal MSLT and a normal orexin level, it kind of makes me wonder, is it something that kind of looks like cataplexy, where you're having episodes of weakness, loss of power, but it's not cataplexy in the usual sense? There is this thing called pseudo-cataplexy that's worth considering. It's a little bit of a lengthier conversation, but and there's things that can mimic it. I mean, there's things that make people feel weak. Like, for instance, if you have sudden drops in blood pressure, you're going to feel weak and you might slump to the ground. And so, if somebody has palpitations and then they suddenly crumble to the ground, I'd think, oh, maybe they're just having a heart rhythm problem instead. So anyway, again, that's another place where seeing a sleep doctor who really knows narcolepsy well and can help tease apart, are these episodes truly cataplexy or something else? I think that would be a good direction to go. Next one is there some connection with pregnancy improving symptoms? Both of my pregnancies, my cataplexy was in remission and I was off all my meds. Elaine, I love this question. And we're actually, I hope in the next several weeks, going to be starting a big survey. I'll put in a plug for it. We want to hear more about women's experiences as they go through narcolepsy, either on or off medicines. I've heard the same story from some patients. It's really amazing to me that, in the interest of being cautious and thinking of the baby and all, a lot of women come off their medicines. And I've heard several say just what you did, where their symptoms got a lot better during pregnancy, much to everybody's surprise. And we don't really know, is it common? Is it something we can plan on? I don't know, but it's something that I've heard from a few people. But I've also heard the opposite too, where people say it's like, not only am I off my meds and feeling sleepy, but I'm exhausted from my pregnancy and it's pretty rough. And so, for some folks, staying on meds is necessary. But yeah, no, it's really interesting. We need to learn more about this because we want to be able to counsel people to give them a sense of the range of symptoms that they might experience during the pregnancy and afterwards. Somebody asks, can there be brain discharge and head drops when narcolepsy starts in children? I'm not really sure what the brain discharge part means, but head drops for sure. And so, for instance, with partial cataplexy, the muscles that hold your head up are often some of the first to fail. And so when people are first developing, sometimes the head bobs forwards, almost in a rhythmic kind of way. That's a very common symptom to have before it develops into a bigger episode of weakness. Shannon asks, related to a previous question, what are some treatments for this or solutions? Oh boy, Shannon, I can't remember what your other question was. Maybe you can type something again to help tie this together. All right. Somebody asks, can sodium oxybates or antidepressants hide cataplexy? Well, I mean, we use those medicines to suppress cataplexy. Somebody can still experience the same emotions. They're laughing, really intensely. They're having a good time with their friends, and they don't have cataplexy because the meds are holding it at bay. So I guess in that sense, yeah. Now, I'm not, maybe you mean something else by hide cataplexy. So if I've missed it, just send another question. The second part of this is, does the level at which you pass an MSLT indicate type 1 or type 2? Yeah. So on that multiple sleep latency test, people with narcolepsy type 1 tend to fall asleep very quickly, like 3 to 5 minutes. People with narcolepsy type 2, on average, it's a little bit longer. I'm going to just say 4 to 7 minutes, but there's a whole range. And so the average sleep latency on the multiple sleep latency test does not tilt the needle strongly towards one or the other. I mean, to be honest, if somebody falls asleep in half a minute on average, I'd say it's probably type 1, but there's no hard line there. Sakara asks, can traumatic brain injury cause narcolepsy, like falling out of a tree at a young age? So this is something that's been talked about a whole bunch. Certainly, immediately after a traumatic brain injury, a lot of people are very sleepy. Usually that gets better over time, but sometimes they can have lingering sleepiness. Now, if we're talking about true narcolepsy, where like type 1, where people actually develop cataplexy and everything like that, there's a theory that if you get whacked on the head, there may be some immune cells that come into the brain, and it may be that you're more likely to have an immune attack on those orexin neurons. However, having said all that, there's actually very little data showing that traumatic brain injury is a frequent thing to occur before the development of narcolepsy. Usually narcolepsy just comes out of the blue. And so I would say at this point, there is no compelling evidence that traumatic brain injury is a common cause. Could it? Yeah, maybe in theory, but hard to say that it does it with any frequency. Okay, we did the narcolepsy type 2 versus IH already. What about disturbed nighttime sleep? How can you help with that for children at night? Yeah. So as I mentioned earlier, we don't understand why sleep is disrupted. I think just in a broad way, you can think of the sleepiness of narcolepsy as people having difficulty maintaining wakefulness across the day. And so the wake is unstable. People sort of wake up for a while, but they just can't keep it going for a long time. And it's sort of like sleep is similar in that sense, that it's just kind of delicate. And the threshold to move from sleep to wake and back and forth is just too low. And so it's easy to transition. And so, yeah, it's a big challenge for kids and their parents, because, in general, we'd like to think that a 10 or a 14-year-old is going to sleep like a champ, right? They usually sleep very deeply. They sleep great through the night. That's often not the case in kids with narcolepsy. And so I think the first question is, in terms of how to help with that, is first, is it actually a problem? Is the sleep not restful anymore? Is there a lot of time being spent awake at night? And I think you got to ask, well, what's causing the sleep disruption? Is there some sleep apnea? Is there night terrors? If there's no obvious thing that's disrupting sleep, it may be just the narcolepsy. But nobody's done proper studies of medicines to ask which meds are most effective for helping with disrupted nighttime sleep. And so currently, we sometimes use oxybates this way, Xyrem, Xywav, Lumryz. We don't give them for the sleep quality at night. We give them to improve the sleepiness in the day and the cataplexy in the day. And as an additional benefit, sometimes you get better sleep at night. And so I don't think it's worth the risk of taking those medicines simply for a sleep benefit. But I think if you're also giving them for the daytime symptoms, you can actually help with some of that disrupted sleep. And there's not really much good data on this, but sometimes people do use other medications. The typical sedating things that are used for insomnia can sometimes be of help. The next question is one that I honestly can't answer. Which med would you start off with for a 4-year-old? First, narcolepsy at the age of 4 is super uncommon, and it'd be really good to make sure that that is truly the diagnosis. In fact, that's a situation if the kid has cataplexy where I'd want to do a spinal tap to just really make sure that we have some good concrete evidence that this is really, really narcolepsy. But then the choice of med is tricky because there's no research done on kids that young. And so it's something you've got to really work with your doc on. Somebody asked if there's any side effects of stopping wake kicks, and the short answer is not really. You'll go back to your baseline again, but as best I know, there's no particular withdrawal, though I don't believe it's been studied formally. Next, sorry to go through these so fast, but there's so many questions. For narcolepsy type 2, do we want more REM sleep or less? How does the whole 24-hour sleep cycle factor into nap planning? Seems like all sleep is deep and long lasting. Yeah, so I wouldn't really worry about how much REM sleep you're getting. Your body will, your body will give you the REM sleep that you need. So, don't obsess too much over what your Fitbit or whatever is, or Apple Watch is telling you. Because I think what matters most is how you feel when you get up. And so as a general rule, we want to make sure that people are getting plenty of sleep at night. If you're an 8-hour sleeper, make sure you get that 8 hours on a good, consistent pattern, going to bed about the same time, getting up at about the same time. If naps are helpful for you, that's terrific. And you want to think of what time of day is that nap going to be most beneficial. For many people, that's usually around 1 or 2 p.m. But if you're one of these people where you go and take a nap and you sleep for 2 hours and you feel groggy afterwards, sometimes the nap isn't worth it. you're just losing too much of the day and you're not even feeling better. So it's, again, an individual thing. For most people with type 1 narcolepsy, naps are great. For type 2 and for some, and oftentimes for IH, it's a little bit less clear. Next is, at what point do you need meds for cataplexy? Is this more so for those that their cataplexy happens daily or multiple times per day? Great question, because it's very individual. You know, we have these meds, but you don't have to use them. It really comes down to how much does the cataplexy bother you? And so, you know, some people say that they just have mild, subtle cataplexy. Only their boyfriend can see it. And their coworkers can't tell. They're not really bothered by it, and they just as soon stay off meds. It's like, fine, great, keep things simple. But then there's other people who, you know, where it's like, oh, this is so embarrassing. I had an episode at work the other day, and now I have to explain it all to everybody. You know, yeah, that's an occasion when you really do want to treat it. So very individual, depends on the severity and the circumstances and what are the sort of things that trigger it. Do the cataplexy meds interact with the sleepiness ones? Yeah, it's complicated. It would take a long time to answer that in any great detail. But certainly, you know, we want to make sure that we're not doubling up on too much sedating stuff and things like that. Can pregnant women take any of these meds? So the only medicine where we have reasonably strong data that there's a problem is modafinil and armodafinil, where you're now strongly discouraging women from taking those when they're ready to start to get pregnant. So even before conception, you should stop those medicines because there's some evidence that they can cause birth defects. Those medicines that I showed on the slides, there's a lot of really potent things there, and you'd think that they might do some weird stuff to the developing baby, but there's really very little concrete evidence that they do. And so just to be cautious, we generally encourage women to really think of, can they get through their pregnancy off meds? But for some, it's just not an option. You know, they're a single mom, they got to drive 45 minutes to work or whatever it might be. Their circumstances are such that they just have to keep going. And so, but you know, for some people, they can sort of make adjustments, like they're going to come off their meds, but they have a job where they can work from home and they can take 2 naps, you know, slide those in amongst their work hours. You know, so there's sometimes ways of making it all work. Next question is, are there any studies on spontaneous remission in cases of narcolepsy? Is this something that doctors and researchers are interested in? Well, yeah, we'd be interested because it's really rare. If narcolepsy type 1 is really due to the orexin neurons dying, you wouldn't think people are going to get better. However, there's a whole range of possibilities out there. And I don't know if you noticed, but on that slide that was showing orexin levels, not everybody with cataplexy has low orexin levels. And so there may be some variability there. And with narcolepsy type 2 and idiopathic hypersomnia, yeah, some people actually do get better over time. And it makes you kind of wonder, was it really narcolepsy? Was it something else? You know, I saw somebody a couple of weeks ago who had a great story for idiopathic hypersomnia, but it turns out it was depression. And when she got on the right antidepressant, all of her IH symptoms went away and she feels great now. Jennifer asks, if TAC-861 makes it through stage 3 trial, how long before it would be available to patients? And I can't answer that too concretely, but as a general rule, the FDA likes to see 2 successful positive phase 3 trials. And then the data is brought before the committee, it's evaluated, it takes months. I would, just in broad strokes, Jennifer, I'm going to say at the conclusion of the second phase 3 trial, somewhere between, I'm just going to guess, maybe 6 and 12 months, something like that. It might get into clinic, barring any sort of problems.
Dr. Scammell, excuse me, do you want to, are you okay, or do you want us to kind of don't want to
like
exhaust
15
you
more
here.
questions. I'm doing fine. I
Okay.
do have, let me just check. Hold on a second. I have a hard stop in about 15 minutes. And so,
okay.
I mean, I could go either way. If you, Monica, what do you want to do?
I can stay. And also I turned, nobody else can send them in questions. So we'll go with these. You can get through these.
But it looks like we still have almost 60 people connected. So I'll keep going here.
Thank you.
All right. So somebody asks, what about numbness in a limb? Can that be cataplexy? And the answer is not really. Cataplexy is weakness. It's not numbness. And so if you have numbness where like tingling, weird loss of sensation with your episodes of weakness, it's not cataplexy. Get checked out by a neurologist. Can stuttering be a form of cataplexy? Kind of. What we see most typically when somebody has cataplexy that affects the voice is it sounds more like slurred speech. It sounds like they're really drunk or super sleepy, where the words just all slur together. If it's actual stuttering, that would be unusual. That would be unusual. Following up on the type 2 versus IH question, is the sleep efficiency result indicative or not of type 2? I've had both PSG and MSLTs done at different times. Originally diagnosed with type 2, then after the PSG, the doctor said probably IH since I'm a long sleeper and I don't have sleep inertia. Well, this is exactly the problem we run into clinic a lot. And so no, the sleep efficiency is not super helpful, but the truth is there's not a lot of our lab tests that are helpful with these things at all. One thing that's good is some sleep labs will do sort of these extended sleep protocols where they'll actually have people go to bed for 12 or more hours and sleep as much as they can. And if somebody has IH and they're a long sleeper, you're going to see objective evidence of long sleep. That's nice. But the trouble is on the routine studies, there's not a lot that strongly distinguishes these two. And so the problem, and just exactly what this person experienced, is that one day the diagnosis is NT2, and then they repeat the studies, and now it's IH. And it's because it all hinges on the multiple sleep latency test. If one day you do the test and you have 2 naps, well, that meets criteria for type 2 narcolepsy. But then you do it again and you only have 1 nap with REM sleep, then now you've met criteria for idiopathic hypersomnia. It's really aggravating for everybody because it shows how bad we are at distinguishing these things. And so I think this is a case where it's really important to really communicate your symptoms and story well, because ultimately, if the test is not super reliable, the story is the thing that's really going to be most important. So what are possible causes when sleeping for more than 16 hours without interruption? Well, if you can do that every day, day after day, then it could be idiopathic hypersomnia. There's a few other things that do that. There's other sort of more worrisome things like, sedating medicines, some horrible neurologic problem, but usually it's pretty obvious if it's something like that. But if somebody who's otherwise healthy can sleep 16 hours every day, that certainly makes me think about idiopathic hypersomnia. Now, just for completeness, if they only do that for a week, and then they're completely better, and then they do it again for a week, 6 months later, then that could be something called Klein-Levin syndrome, which is intermittent episodes of long sleep. All right, next one. Add on to the NT2 question. I'm not sure I understand this from an anonymous attendee. It says PS, oh, maybe that means PSG doesn't meet idiopathic hypersomnia category because 4 REMs were noted in nap testing. Yeah, if you have REM sleep and 4 of the naps, it certainly tilts the needle much more towards narcolepsy. Shannon asks, on meds, daughter takes meds for depression, ADHD before this diagnosis, adding Lunesta, which is a sleeping pill, to help with going to sleep and get better sleep. Doctor recommended trying Jornay PM to help with waking, but would have to stop taking Vyvanse, which has been helpful with the ADHD. So Jornay PM Jornay PM is an interesting medicine. It's a medicine that you take at bedtime, and then the drug does nothing for 8 hours, and then it's released way down in the intestines. And so it's got a timer on it. And so what's cool about it is that for somebody who has a really hard time getting up in the morning, you take it at bedtime when you're alert, but then it'll kick in 8 hours later to help get you up and out of bed. And so I think it's something worth thinking about for people with morning sleep inertia. And it does last for a long time once it's released. So it actually will probably substitute in for the Vyvanse because it's essentially the same kind of medicine. And so even if the person has to come off Vyvanse, the Jornay will probably be providing similar ADHD kind of benefits. Can you have both narcolepsy type 1 and hypersomnia? Yeah, not really. We'd really like it to be one or the other. It's just sometimes hard to tease them apart. But if somebody has clear cataplexy and they have really long sleep times and really hard time getting up in the morning, that's a pretty complicated picture, which is, to be honest, kind of uncommon, but sure, it's possible. It'd just be very unlikely. I've heard that many narcolepsy patients can be more alert in the later evening. Is that a complete myth? Or if you have narcolepsy and feel late evening is their time, should they treat a biologic clock issue too? Yeah, that's a great question. A lot of people with narcolepsy feel horrible in the evening. They have they get their best work done, they have their most energy in the morning, and then at the end of the workday, they get home, they barely cook dinner, and after dinner, they're just shot. So I think that for most people with narcolepsy type 1 and type 2, evenings are really difficult. Having said that, as we talked before, people have different internal body rhythms. And so, some young people with narcolepsy are going to have circadian phase delay too. And so they might actually really perk up at night. And then one of the challenges there is if they're staying up till midnight because they're feeling alert, then they may have a really hard time getting up in time for school. So you can have circadian rhythm disorders in combination with narcolepsy, but most narcolepsy patients are pretty beat, by 6 p.m. Leslie asks, I was actually wondering if post-pregnancy would bring it on worse or really trigger narcolepsy. I'm not sure what you mean by it. Leslie, you might want to just type your question again. Shannon asks, my meds question was for the extreme difficulty in waking up in the morning. Shannon, I don't remember what the other question was. What was she asking? Monica, do you remember?
I can't remember. There have been, 47 questions. So I think the
Yeah,
whole question has to
sorry.
be retyped.
Yeah. Spell it out at length if you want. Are there any other sensations with the muscle loss of cataplexy, like tingling or numbness? Yeah. So Ben, that's an interesting question because I said before, cataplexy does not cause numbness, but people do describe sort of a weird, very hard to describe sensation, like a wave of something that tells them that the cataplexy is coming on. So it's not numbness, it's not tingling, it's not pain, but there is an internal feeling that I've never heard anybody really properly put into words that says my cataplexy is about to come on. Sandy asks, I was not told to go off my antidepressants for 3 weeks before the sleep study. Does this mean my test results are invalid? Yeah, great question. I think it sort of depends on what your doctor was thinking. If they really wanted to get a clear, really rock solid multiple sleep latency test, it would be good to come off the antidepressants because antidepressants suppress REM sleep, and we're looking for REM sleep on those daytime naps. So I have to say this comes up pretty commonly where somebody has a multiple sleep latency test done, but then when we look into it, we're like, oh no, they were still taking these medicines. And it just ends up producing lots of questions like, is some of the stuff we're seeing on the multiple sleep latency test just an artifact from the drugs? And so most commonly what you'd see if somebody takes antidepressants through a multiple sleep latency test is you see a suppression of REM sleep. And so the picture might end up looking accidentally like idiopathic hypersomnia because you're suppressing the REM in the day. But, I certainly have had some patients where they have real depression and there's no way we're taking them off of their antidepressants at this time. And in those folks, we'll just do the test because we have to do the test. And at least we get a measurement of their sleepiness. But you got to acknowledge in the test report that it may be contaminated by the concomitant meds. Okay.
Wow.
That was a lot of
Amazing.
questions. And honestly, I really appreciate all the engagement and the depth of expertise. I mean, really, this was supposed to be Narcolepsy 101, and we got to some of the graduate level questions.
Awesome. Thank you. I mean, I don't think people have the opportunity to ask, you these questions. So I appreciate everybody sending those questions in. Just to wrap up, I'd love to thank Dr. Scammell for sharing such important and relevant information about narcolepsy and answering all of these questions. And thank you to our sponsors for enabling Wake Up Narcolepsy to bring the Brown Bag webinar series to the community. Thank you to Avadel Pharmaceuticals and Takeda Pharmaceuticals. So thank you. Have a wonderful afternoon, everybody. Thank you, Dr. Scammell.
Okay. Bye-bye.
Talk to you soon. Bye-bye.